get everybody's attention. We're going to try to get started here. We are a few minutes after 11, and I believe we got everybody up here that's going to be up here. We normally have one of us in our group do the invocation, but we've got the CEO here, and I think we can get him to do it for us today in his hometown here. Please, and that we appreciate it.
Okay, good. My honor. Please bow your heads. Dear Heavenly Father, we're so grateful that we're here together with this leadership team. We just ask you to guide and direct us as we study, as we learn, and as we make decisions that affect millions of lives. We're just so grateful for the skills and the talents that you've bestowed on this group, and may we use those to your glory. And may your healing mercy be on all those that we serve. It's in your name we pray. Amen.
Very quickly before he starts, we will have an introduction of everybody here at the group. I know we've got Patrick is out of the country, and I believe that one of the house members is here. But, well, I guess I got to pass the microphone to do that. So anyway,
I don't think it's working.
is this something, y'all have this on? Oh, there it is. Is that okay? All right, anyway, we will, yeah, let's just start on that end with James, and everybody will be successful.
I'm James Beal with the Senate Research Office.
Good morning, this is Senator Gloria Butler, representing parts of DeKalb and Gwinnett counties.
I'm Senator Ben Watson, and this is my district, and I practice medicine in that hospital in the Southwest.
I'm Senator Renee Unterman. I represent Senate District 45, which is northern Gwinnett County.
And I'm Chuck Hustetler, one of the co-chairs, and my district is Rome and Carson County, about the furthest angle north of here that you can get in the state.
Representative Markey from the Augusta and Columbia County area, just up the road, driving distance. I'm an emergency physician, and I represent that area. I'm co-chair on the House side.
Representing Sharon Duggar, I represent East Con, I'm chairman of Health and Human Services, and one area that seems to be of interest to some people here today is Mark and I are co-chairing a maternal mortality study group.
Good morning, Mike Molchek from the House Budget Research Office.
Okay, so this time we'll hear from the CEO. I believe he's been here, what, about 18 months now or so?
A little over 18 months.
And have him tell us a little bit about Memorial and the healthcare down here. Thank you.
Yeah, thank you very much. Welcome to everybody to the Savannah campus of Mercer University School of Medicine and Memorial Health. I'm Shane George, CEO here at Memorial Health, and we are pleased to host your study committee today, and want to thank you for your service and the work that you do for all the people of Georgia. I want to share just a brief success story, really, on the journey that Memorial Health has been on. And just to let you know, my career actually started in Georgia. I was up in Gainesville, Georgia, as a young administrative resident up in Lanier Park, up in that area. Started my career there. I've also got an MBA and an MHA from Georgia State as well, too. So just spent previously 11 years at Doctors Hospital in Augusta as well, too. So we call Georgia home, and now it's my pleasure to be CEO here at Memorial Health. I want to tell you just a little bit. Memorial Health exists today because of some visionary leadership of a group of local veterans and community leaders. You know, following World War II, the group sought to create a memorial to honor 527 of Chatham County residents who died in the war. After considering a lot of proposals, they decided that Memorial would be a new state-of-the-art hospital, and the facility would offer medical services that had not been available in Savannah at that time, and also train physicians and nurses as well. And so October 21st, 1955, Memorial Hospital of Chatham County opened its doors to a brand new 300-bed general hospital dedicated as a living memorial to our nation's war dead. Today, we're a 612-bed tertiary facility. We're one of the largest employers in the area. Comprehensive comprehensive clinical services. We have the only level 1 trauma center in this region, level 3 neonatal ICU as well. And we just joined the HCA family. We're a big family here on campus, but we're also a part of a large family, the largest private healthcare company in the world, Hca Healthcare. I wanted to give you just a little perspective on Hca Healthcare. We own and operate 186 hospitals in 20 states and also in the United Kingdom. We see approximately 30 million patient encounters every year. We have the largest healthcare data reservoir in the world. So we're starting to mine that data now and create best practices. I think that's when HCA is at its best, is when we're sharing best practices all across our country. You can see the map here. We do have 9 hospitals in Georgia. We're hoping to add a 10th. We're in due diligence now with Meadows and Vidalia. So we're going through that process as well. You can see a little bit of the numbers here. We about 270,000 colleagues all across the country. We employ almost close to 100,000 nurses across the land as well. Here's a little bit of information on Memorial Health. 612 bed license, as I said. We're getting close to almost 100, I think we're going to hit about 110,000 ER visits this year. We've got a transfer center. We transfer in about 10,000 transfers every year from all over the region, the rural areas as well. So we do about 3,800 traumas each year. You can see 28,000 pediatric ER visits. Just back across the parking lot, we are in the process of building a freestanding children's hospital. I'll talk about that in just a second here. We employ a large amount of employees here with salaries, wages, and benefits, close to $250 million. We do care for the uninsured and the underinsured. I wanted to share this stat with you, $60 million each year that we care for the underinsured and the uninsured. And we are a tax-paying facility as well. So we look forward to paying even more taxes here soon. This is a busy slide, but I wanted to show you the commitment to growth that we have. HCA is a company into Memorial Health here in Savannah. We are investing in deploying rapidly over $300 million in investments across the board. Particularly in our children's hospital, which is right here on campus. That's that is a $65 million project. We're also building out our 3rd and our 4th floors in our heart and vascular tower that was shelled in. This is all occurring in the past 18 to 20 months since Memorial became HCA in the HCA family. We're investing heavily in robotics now. We have 4 robots that are actively working with our surgeons. We're becoming an epicenter for training for surgery as well too, in some of our general surgery and our OB/GYN residencies. You can see some of the other investments that we've made in outpatient surgery centers, new cath labs, a whole new central sterile processing which supports our surgery, our behavioral health unit. We made investments there of about $4.5 million. New linear accelerators in our Cancer Institute, and on down the list. And you can see a lot of the facility infrastructure and upgrades. We're rapidly deploying capital and things you can't see. These are to keep the sustainability of the facility working for a long time, keeping the lights on, the air going, and supporting patient care. Our children's hospital, it's an exciting project. We're building a 50-bed children's hospital right here on campus. It'll be the largest freestanding children's hospital in this region. List of the pediatric services here you can see. We just had a milestone on October the 3rd. We had the final beam signing that we lifted up. Everybody signed it, and it was a great day for Memorial Health. And the ribbon cutting we are expecting, and everybody here is invited to that ribbon cutting in the 4th quarter of 2020 next year. So we're excited to see that. That hospital is going to include 50 beds. It'll have its own pediatric emergency room as well. There'll be 18 beds, 15 pediatric ICU beds as well. It'll have 4 ORs, dedicated MRI, dedicated CT as well too. So it's going to be a great, another gem here in this region of the state. Also making significant physician investments. We've been able to recruit well over 30 providers in our 18 months in various specialties. A lot of those are pediatric subspecialties, getting us ready for the Children's Hospital. We have 140 residents in 6 programs: family medicine, internal medicine, OB/GYN, pediatrics, surgery, and diagnostic radiology. We also have 2 fellowship programs as well: primary care sports medicine and our surgical critical care. And we're affiliated with, of course, Mercer University School of Medicine here. Other clinical education, we are working very closely with colleges and universities throughout the state and outside the state as well, giving clinical education opportunities as a teaching facility here at Memorial Health. And we had over 1,100 students rotating through the facility in 2018. You can see we're dedicated to quality. This is one of our pillars of success. The Joint Commission, I don't know if you're familiar, the Joint Commission is our big survey with the federal government every 3 years, and we are expecting them in tomorrow. So we've got a lot of people working diligently to make sure that we stay on top of our game. We can't wait till they come in. And we're also primary stroke certified. There's a few other accreditations and accolades here listed that you can see, from chest pain accreditation to some of our Blue Cross Blue Shield distinction centers for bariatric as well. We're also, over the past, in 2018, we made $250,000 in donations to local partners and charities. So we want to make sure that we're a good community partner here as another pillar of success for Memorial Health. And you can see some of the other organizations that we are participating in, but we're pleased to be able to make those donations as well. This is actually my last slide. Wanted to share this journey that we have been on at Memorial Health. You can see the dip from 2015 down to 2017. That's just unsustainable. And that is a negative margin. You can't operate in that area for very long. And the acquisition of HCA occurred in February of 2018, and you can see the bend in that curve, and we're just proud to show this kind of a financial turnaround while making those big investments into Memorial Health. So very proud of that, and proud of all the investments that we're making in technology and services moving forward here at Memorial Health. That's all I have. I'd be happy to answer any questions, but I know you've got a busy day today. So I wanted to say thank you for giving me the opportunity to speak to you, share this quick journey that we are on at Memorial Health, and we're proud to serve this community and our state as well too.
The only question I did have was, if I remember right, HCA is the #1 provider of behavioral health in the country. I think I heard that somewhere. We've certainly got those issues in our state. So if we can have you help us make some of those turnarounds too, like's happened here, because I don't think there's been a bigger turnaround from not just financial, but facilities and everything in the state of Georgia than this hospital has been in the last year or two. So
we're continuing to focus on all those service lines, and we do have opportunity. We'd be happy to work together collaboratively.
Yeah, I do appreciate that. Behavioral health was certainly a key one. I think you said over $4 million. Is that a new facility or just expanding one that was?
Yeah, we have a behavioral health center, which is what we call our Clark building. And it's a 26-bed facility, freestanding right out here on the front of the campus. And we had some ligature issues. We had a lot of environmental care type issues as well. So we made a lot of investments in a short period of time to make sure that we were up to code and it was a safe environment for the behavioral health patients.
I know there's some people from all over Georgia. What I heard was pediatrics, a level 3 nursery, OB residencies, training OB doctors and others, and G&E we used to do at the state capitol. 10,000 transfers from rural hospitals around this region. I think way across, and you mentioned Vidalia.
We did.
I just appreciate what you guys are doing, making it such a big part, something that wasn't on a good trajectory from everything I was reading and following, but now to see it on a stronger trajectory, even paying taxes to the local government bodies. I think I appreciate you guys hosting this and working with Mercer to do that too. I think it's a great part of the state. It's good for us to get out of Atlanta or Augusta or other places. So Thanks for hosting us.
Yeah, thank you. And Savannah Memorial is just an absolute gem. We wanted to take the best of Memorial and the best of HCA and bring that together. And just very excited about the success that we've seen so far. So thank you very much. And at this time, if I could, just wanted to note out, we have our Chief Nursing Executive, Dr. Nina Evans, right here. She's joining us from our South Atlantic Division. We are part of a division of HCA that has 12 hospitals in our division, South Atlantic Division, that reaches as far as Myrtle Beach in South Carolina, all the way down to Jacksonville, Florida, and our Georgia hospitals as well, too. So thank you, Dr. Evans, for being here today.
Absolutely. Thank you.
And I think now I was going to introduce Dr. David Baxter, who's Associate Professor of Medicine here at Mercer University School of Medicine. And Dr. Baxter.
Thank you. It is a privilege to work here in Savannah, and it's my honor today on behalf of Jean Sumner, who's the dean, who had commitments she could not break. She was very disappointed she couldn't be here, because this is a great area of interest to Jean. But it's so important. I'm thankful for many things. First thing I'm thankful for is sitting in the back named Stan Daniel. He is always quietly making sure everything actually works. And so Stan, I want to thank you for that. And it's also important to me on many levels. I'm thankful and honored to be here. I wouldn't be alive if it wasn't for Mercer University. My parents met. My daddy was a preacher and met my mother. He was from Haralson County. She was from Gainesville, Georgia. They met and married, and I'm alive because of Mercer. So I'm thankful on many levels for Mercer University to say that. And it's an honor to be here, to be part of the School of Medicine. I teach internal medicine at the clinic over at Memorial, and I teach first and second year medical students. I primarily focus on teaching them how to doctor. I teach medical practice or clinical skills. I teach them how to do the doctoring part, which I think is the most important part. And so that's my area of interest and joy, and it's a joy. It's a joy to be here to tell you about Mercer. Mercer Medical School started with the state of Georgia's help in 1982. Started in a small class there in Macon. In 1996, they added a clinical campus where third and fourth year students came and started working at Memorial. In 2008, they seated the first four-year class, first freshman class was seated here. 2008 started with 20 students. Now we have 60 students in each class. It's the same size as the Macon campus. So we've expanded with the help and the continued help of the state of Georgia, and we appreciate it very much. Mercer continues to lead nationally. We have the accelerated care track. It was started on this campus in Savannah, Georgia by the Family Medicine Department and by Texas Tech. No matter what other people say, it was started here and in Texas Tech. It's now being carried throughout the country, a 3-year program. We now have 41 students in the accelerated track where they graduate in 3 years and they go to primary care in the state of Georgia. We also have, in addition to that, the Nathan Deal Scholarship. Governor Deal saw that we had some monies that because of the budgetary reality in the mid-2000s, and he gave us that money. He said we can use that money for anything. What Jean Sumner and President Underwood did was to make that back into the people of Georgia, and that's scholarships for medical students. So that money is being spent to educate physicians in Georgia. Also, Mercer Medicine that now has a rural PhD program. Also, President Carter needed a doctor in Plains, Georgia, so Mercer Medicine built a clinic there in Plains, Georgia, with the help of the state of Georgia. Also in Fort Gaines, they've started one, and there's another one starting very, very soon in Clay County, Fort Gaines. It will start next year. Fort Valley started October the 1st. We only admit students with Georgia roots, and so far in the class we've accepted 52% of the people come from the rural and underserved. So we thank you for the opportunity for you to be here. We thank you for what you do for Mercer, what you allow us with you to do for the rural and underserved of Georgia. So thank you for coming. And welcome.
Thank you very much for that presentation. And at this this time, we've got a couple of call-in people from the other end of the state that are I believe, affiliated with the WellStar system. Are we got them where they can,
We should be
Good morning. Good morning.
all right, is this Jill?
It is, sir.
Okay, well, we're gonna go ahead and give you the floor. You know the time limit, I think, and you can go ahead and get started here. And introduce
Thank
yourself
you.
first.
Yes, sir. Well, first I'd like to thank Senator Huffstetler, Representative Newton, and the committee members for this opportunity. I would like to introduce myself. I've been a physician assistant for 16 and a half years in the state of Georgia, where I also attended PA school at the Medical College of Georgia. In my current role, I'm the Chief of Advanced Practice Professionals for WellStar Medical Group. I am currently accountable to the oversight of more than 550 advanced practice professionals. We serve 11 counties, 11 hospitals. We have over 280 offices and 50 urgent cares. I directly report to Dr. Rob Schreiner. He is the president of WellStar Medical Group and a respected member of the medical. In the interest of conserving time for questions, I would like to introduce Charmaine Hca, assistant, who will be jointly presenting with me today. Good morning, honorable senators and representatives. My name is Charmaine Hca. I have been practicing physician assistant in the state for the last 17 years as well. For the last 5 years, I've had the privilege of serving the state of Georgia and its citizens by serving as the PA ex officio on the Composite State Medical Board. This role has provided me many opportunities to meet state legislators, some of which are in attendance today. It has also afforded me the opportunity and insight to work closely with all of the physician board members, ensuring the safety of healthcare delivery for all Georgians. I currently work in a practice with 19 APPs. I couldn't honestly say how many are PAs or how many are APRNs because we all function in the same role, providing the same care each day. With this in mind, I am thankful to both the House and the Senate members here today dedicated to streamlining and simplifying physician utilization for both professions to further healthcare access to many more Georgians. Mr. Chairman, do you have in your possession and the other committee members the PA and APRN language that I shared via email?
That I'm not sure if we do. I'm looking for it to mail out paper print. And I know you did send that, so we'll make sure we get that
Okay.
in everyone's hands. So
Thank you, sir.
Go ahead with your presentation. We'll make sure everyone gets a copy of that at the end.
Thank you. This is Jill. We would like to present a few issues or constraints affecting the utilization and compliance surrounding APP practice, specifically where it relates to the limitations in staffing our underserved areas. Our first item, limitations of practice. In looking at Rule 360-5.11, Item 1, physician assistants are restricted and often overlooked as a profession for employment in underserved areas in both primary care and urgent care offices due to the requirement that the physician must regularly see patients at that facility or office. On the contrary, APRNs only require the physician to be licensed and practice in the state or within 50 miles of the location if said office is out of state. Due to this statement, we are left with limited options to provide services within these remote offices by physician assistants. We typically utilize APRNs due to the statement limiting overall access. Because of these constraints, it seems reasonable to equalize the scope of practice for both APRNs and physician assistants. This will further increase the capacity to provide quality health care to the patients in underserved areas where offices and urgent cares are located or needed. Item number 2 will be particularly where it relates to the compliance within large medical groups. working with electronic health records is chart review. If you could, we will reference Rule 360-5-.12, Item 8, as well as Rule 360-32-.2, Sections 7 and 8. Physician assistance rule requires a physician to review no less than 50% of all charts when a prescription or drug order has been written every 30 days. Whereas nurse practitioners require chart review for 100% of charts where a controlled substance has been written. Otherwise, the physician is only required to review a sampling of 10% of charts annually. In my system, electronic health records are not capable of delineating between disciplines where it pertains to APRNs and PAs, as they are utilized in the same capacity within the medical brief. Furthermore, it concerns me that physicians may be unable to meet the minimum requirements for chart review given the broad differences for PAs versus APRNs.
And lastly, the item for consideration is the physician to advanced practice provider ratio regarding supervision and delegation. Please refer to Rule 360-5-.05, Item 4, and 360-32.04, Item 4 and 5. All of these rules that we're referencing are in the email and outlined in the email, so hopefully you'll have that available to you soon so you can reference. As you know, legislation was passed last year in the state of Georgia increasing the ratio of APRN and AA supervision delegation by physicians from 4 to 8. The law remains 4 for physician assistants. Again, limiting our ability to expand our reach to care for patients in rural and underserved areas. You may be aware in your research that South Carolina recently equalized this to 6 for both APRNs and PAs in their state. Perhaps we should consider a similar statute. In conclusion, when comparing the present legislation for physician assistants and APRNs in the state of Georgia, it seems reasonable to consider equalizing the language to further the reach of medical care. By simplifying this legislation, it creates a greater opportunity for physician assistant workforce to provide quality medical care in continued collaboration with our physician colleagues, particularly where it pertains to rural and underserved Georgians. We have concluded our testimony, and we would appreciate at this time any questions that you may have. And again, we thank you for your time.
Thank you all for your time too. And looking over these 3 areas, if I could summarize a little bit, you've got a group of PAs and APRNs that basically do the same job, but the first thing is the geographical location is different between the two. And then the second thing, you have to have 50% of your chart reviewed. Now you said the APRNs would have to have 100% of their charts reviewed when it's narcotics involved, but since Georgia is one of 5 states that they don't do narcotics, and that rule really doesn't apply in the state of Georgia at the present time.
That's correct, so yes.
So it would be
So
50% versus 10% is the reality right now in Georgia. And
well, 50% monthly for PAs, 10% annually for APRN.
okay, and I missed that point too, the annual versus.
That's right.
And then the ratio is, as we have looked at our last meeting at the changes South Carolina has made, and I know we'll have a presentation about the changes for APRNs that were done here previously today, trying to simplify that ratio. I do want to make the point, when the AAs went from 4 to 8, it's still only 4 supervised at any one time. They can sponsor up to 8.
Correct.
But only 4 at any one time could be working. So the ratio stayed the same. It was really done for the case of there may be moms that were job sharing, and it limited their employment because they were at a disadvantage to the anesthesiologist for that. So anyway, I think those are valid points, and we can certainly look at those. Any questions or comments from the committee?
This is Senator Ben Watson. In visiting with the Composite Board of Medical Examiners, some of the disciplinary issues relating to advanced practice personnel, whether it's PA or nurse practitioners, the Composite Board can certainly has purview over PAs, but with the nurse practitioners, there's been sort of a gaping hole if that's been playing a role in disciplinary actions relating to either. And that includes testimony and so forth. Would you be advocating for a less disjointed review and maybe bringing together nurse practitioners and PA under one roof?
Absolutely, and I know that the medical board has stated in the past that they would welcome APRNs under the scope of the medical board as they're presently under the scope of the Georgia Nursing Board, except for where the protocols are concerned, because APRNs are practicing medicine. We feel that for the safety of Georgians, it might be best for them to be supervised underneath medical board. They can't take our practice. Hello?
Yeah, we've got one mic and we're passing it back and forth here.
Oh, I'm sorry.
No problem at all. Any other comments anyone has or questions? I don't think so. I mean, I think you've made it pretty clear there's three areas that you would like to look at, and I think they look reasonable in my mind, but we'll see what the committee as a whole, and then eventually how the Senate and House as a whole look at some of these things in the coming session. All right, no other questions. We thank you for your time and for having it concise and to the point.
Thank you, sir. Our pleasure.
Okay, we have a Tina Hood, I believe, is the next presenter. Tina, if you want to come up to the front up there to the mic.
Good morning. Thank you again for allowing me to speak to you again. I'm honored to speak to the senators and representatives. Many I've spoken in front of before. Really appreciate you giving me your time. I currently am a PA. I work in rural health. Rural health is a huge passion of mine. I also serve on the physician task force workforce, working with Sharon Hughes as far as helping with the scholarships and stuff for PAs and stuff in the state of Georgia. The governor initially started out with 10 scholarships and increased it last year. So actually by doing that, and the requirements are that they have to stay in the rural areas, it actually opens up more access to care, and I really appreciate you guys voting for that. There's a couple of things that I would like to talk about. Charmaine and them brought it up about the ratio and stuff. In the rural hospitals, we're kind of limited by the ratio as far as the number of PAs and stuff that can be assigned to a supervising physician. You can have as many alternate physicians as you'd like, or they can supervise as many PAs as they'd like. One of the things that we run into a problem is if it takes more than 4 PAs in a local area to serve as far as in the emergency room and stuff. We cover that 24/7, every day of the year and stuff, and it's going to take more than 4 providers, which, typically we have the local physicians who sign on as our supervising doc, and then we have a list of alternates as well. If you have, like I'm credentialed at Millen in Sylvania, and also credentialed down at Lakeland and Whitman. Whereas if we have somebody that is out sick or has to have surgery, we have to scramble to kind of replace that coverage and stuff like that. And if you don't have somebody that's already assigned a supervising doc in that area, it can run into a problem. Whereas if we could plan ahead of time, where we have more PAs listed under a supervising position, I think that's going to help us as far as covering for the rural areas. Another thing that I would like to talk about, and I've talked to many of you about it before, is the hydrocodone bill, which I know that there is an opioid problem, and I have not, I still feel the same way about it. And I've talked with Representative Cooper before about how I feel about it, but I still think that there's a need in the rural areas where, we're not asking for like 30-day supply or anything like that, even limited to a 3-day supply. But there's a need in the state of Georgia in the rural areas where you have mid-levels covering an emergency room. Say if someone comes in with a bone or kidney stone, or there, areas that typically if there was a physician, covering that area at that time, that they would write for, Morco or something like that to kind of help them with it. I do realize that, like I said, we have the opioid problem and stuff. I know that the state of Georgia is one of the most restricted in the United States. I've had several patients that have had broken bones that have had to come back to the ER multiple times. So that's a cost issue. As far as, and then not only that, just the discomfort of the patient. I feel like we're really failing our patients by not being able to provide this service, at least for just a few days until they can get in to see the physician. Now, most of you, which I know you've heard me say it before, but for the representatives and senators that have not been on the committee before, I'd like to say it just because, so that you would understand. Whenever we have someone that comes in with a broken bone, typically, years ago, they would go through, they would put a cast on it, and then, the physician would see them and then let them go home and write the prescriptions and stuff. Nowadays, what they do is they allow the swelling to kind of go down from the injury. We put a splint on it, and the actual physician doesn't see them for at least probably 2 to 3 days. With kidney stones, those that are less than 5 millimeters, the urologist is not going to get them in until at least 2 to 3 days later, repeat the x-rays that we've already done in the ER. So then you're just kind of going around with a broken bone or either a kidney stone with Tylenol 3 or 4 per pound. And any of you that have had, kidney stones or broken bones would know that this really, we're kind of failing in this area. And we're not asking for like, 30-day supply or anything like that. We're just asking for a few days, if y'all would consider that again. I know that in the larger areas, the physician they have more access to the physicians and stuff, and it's not, the orthopedic guys are right there, and typically they can get them in a lot faster. But it's not that way in rural areas. And then access to care as far as driving to the facilities or driving to the doctor's appointments and stuff like that, that's a true problem in rural areas. Many people come to the rural hospital that really need to be at the larger hospitals, and we transfer them out, but they come there because they can't drive to a larger area. We're that first door that they come into. And, I just wish that at some point that we could consider maybe meeting the needs of the rural health in Georgia. And again, I really do appreciate you guys letting me talk. I know that I heard Senator Hofstadter talk about behavioral health. That's a true issue in rural areas. We have people that sign in and, we have to sign a routine on them. And we don't have security and stuff like they do at the larger hospitals. And a lot of times they're just sitting there for days waiting for placement. So I understand that you have a committee that y'all are working on that, and I appreciate your working on that for us. Do I have any questions?
Thank you, Tina, and I know you've come up to the Capitol business there as well, and,
yes,
and you've been active in the organization. Any questions?
Actually, I have 2 questions. I just wondered, orthopedic practices in the rural areas, do those predominantly employ physician assistants?
I think they have both. I know that a lot of the times, like when I'm working in Sylvania and Millen, I mean, they have Sylvania has an office where they'll come every so often, maybe once or twice a month. Otherwise, they've got to go to Statesboro, Savannah or something like that. Typically, the doc comes, sometimes the mid-level provider will come to do follow-ups and stuff like that. But as far as seeing the patient when they're injured at that point, they have to go to the other areas for treatment by the physicians and stuff.
I visited that hospital in Sylvania, just amazed at the turnaround is phenomenal, what it's done for that area. My question is about in the orthopedics. When you're a physician assistant, you can order a CT scan and MRI, right?
That's correct.
But an APRN cannot order it, right?
I don't really know the particulars of the APRNs. I'll let those, the APRNs, I'll let them discuss that with you and stuff. But yes, now in the emergency room, we have to be able to order CAT scans and things like that.
Thanks so much, I appreciate that. I know we talked earlier ahead of time, and I grew up in Twin City, Georgia, just near, not too far from Midland and not too far from Sylvania from that perspective. From a physician standpoint, the trauma surgeons here at Memorial, for fractures and so forth, and going out of the emergency room, the emergency room is using a lot of the tramadol and the codeine number 3, which if you look at the data on that, there's absolutely no difference between hydrocodone and codeine from a pain relief standpoint. And that's not much better than Tylenol itself. The trauma surgeons now, compared to 5 years ago, send patients home with, what do you think? Well, they Tylenol. How many narcotic pills do you think they send them home on now? Trauma surgeons here at Memorial, and they're some of the best in the nation.
Oh, yeah.
They send them home with 3 pills. And I'll tell you, that's a difference in the perspective of how we look at substance abuse, pain relief, and acute care. So I applaud you for what you're doing in rural Georgia and Midland and Sylvania and with Optum. Optum's been a fabulous, a very good asset from Tattnall County to Midland, Wisconsin, to all over. So thank you for what you're doing, and we appreciate you testifying. Thanks so much.
Thank you.
All right, any other questions from the group here? Not seeing any, I think you're done, and we appreciate you again coming and giving us testimony on our meetings.
Yes, sir. Thank you. I appreciate it.
Okay, we'll keep moving if everybody's okay with that. We're actually doing pretty good on schedule. Hca Health, who is an APRN, and I believe she's working on a PhD, and she is a CRNA, but she's not here talking about the CRNA issues, I understand it, because I know the CRNAs made a point that they didn't want any changes, and neither did anybody else in the anesthesia, I think. So that was the question, and they had actually contacted and said, we still have that same position, and we said, we understand that, but you were here on a different issue. So with that, the floor is yours. Tell us a little bit about you and what you're here for.
Thank you so much. My name is Hca Health. I am an Augusta University doctoral student, and this is my doctoral project. And I asked to come speak today because my project was on an educational policy initiative to improve maternal and infant mortality rates in Georgia. And that, I think, expanding scope of practice will help address that issue. So, the purpose of this project, we found that there was very little information on topic of education and intent to create legislation. So, and what legislators' interests, what informs their intent, and how they prefer to receive information, whether that be through a blog, through PowerPoint, through a lecture, etc. So, getting back to the topic of maternal mortality rates in Georgia, we know that pregnant women and children are most vulnerable population demographic, and this is regardless of what culture or country you're speaking of. And in Georgia and in our nation, 60% of maternal deaths are preventable. In Georgia, this is one of the interesting things. To me, Center for Disease Control and the Georgia Department of Public Health and one other organization, I believe it's Society of Obstetricians and Gynecologists in Georgia, look at maternal death rates from when a woman first finds out she's pregnant until a year after delivery. However, the World Health Organization looks at and tracks maternal death rates at when she first learns that she is pregnant until 42 days afterwards, which then creates an apples to oranges scenario. But no matter how you slice it, Georgia has still a very high maternal mortality rate. And the health of pregnant women and unborn children are harbingers of the overall health of the state, region, or nation. So we know that 60% of our pregnant women in Georgia receive their health care through Medicaid, which ends 60 days after delivery in Georgia. Some of the reasons for our maternal mortality following delivery are chronic conditions related to hypertension, obesity, which continues to grow and increase and be a problem, diabetes, heart disease, valvular disease, depression, suicide, and overdose. Some of the dire statistics, Georgia leads the nation in maternal deaths with 46.2 per 100,000 births. The infant mortality rate is 6th highest in the U.S. At 7 deaths per 1,000 births. The southern region leads the nation as a region in the U.S. for the highest maternal mortality, and also for one of the highest in the industrialized world. And some of the causes are related to poverty with reduced resources, especially with transportation. When you look at it, we have many medical deserts in our state. I live rurally, population 350, Bostwick, Georgia. We don't have Uber. We don't have taxi service. If you don't have a ride, you get your family, and if they don't have a ride, then you're kind of in a difficult spot. And many women are traveling 200 miles for prenatal care. So there's a lack of access to care, especially rurally. And the other issue that informs this is there's poor prenatal care to begin with, and obesity is a huge issue. So Georgia leads the nation in the 3rd largest number of rural hospital closures nationally. We're the 2nd largest number of rural hospital closures in the southeast, followed only by Texas. I was an intern last summer at the CDC, and I worked for the division of OPHPR, which is disaster preparedness and management. I'm interested in that. And some of the most robust vital statistics we could find was in death rates for women and children in that demographic. And it's often something I think that the federal government does not look at. They mandate for any providers that work in a rural area, they must do disaster preparedness and management if they bill for Medicare and Medicaid. But if you have no providers there, you cannot address disaster preparedness and management. And I live off of I-20, we are on the disaster route from Florida. We have these women in a low pressure system coming up from Florida, and they're all going into labor, looking for a safe house to have their babies, and they can't find one. So when you look at rural hospitals, they are often the main economic driver of a county, and they're the main employer. When they close, the providers leave town, that infrastructure leaves, they take their children with them, the community dries up and you have a medical desert. In Georgia, from 2004 to 14, 60% of rural hospital obstetric units closed. 30% of rural hospitals in the U.S. currently offer OB services. That's not much. And like I mentioned before, maternal transportation is a critical issue for adequate prenatal, internatal, and postnatal care. So when you look at it, a rural hospital added to a healthcare desert creates a lack of providers because they all leave town and reduced access to care. There are 159 counties in Georgia. 90 are currently considered rural with populations of less than 40,000. Here again, you get into a discussion about definitions. When I was at the CDC, there are 70 federal definitions of what constitutes rural. Then you have the pioneer states of Idaho, North and South Dakota, Montana, Wyoming. Idaho only has 1.8 million people in the entire state, and their capital only has 200,000. You really can't compare them to rural Georgia. So that's another issue where the definitions create lots of problems because we're not all talking about the same thing. So when a hospital closes, a medical desert is formed. Georgia is known, as we've heard, as one of the most restrictive states as far as scope of practice, which creates an exodus of healthcare providers out of the state. We know that state regulatory restrictions limit providers' scope of practice, but they don't necessarily lead to a higher quality of healthcare. And Georgia's high maternal mortality rates cannot be equated with better, safer healthcare outcomes with current regulatory practice restrictions. So the World Health Organization weighs in and says policymakers should consider educational, regulatory, financial, personal, and professional support interventions to recruit and retain healthcare workers in rural and remote areas. This is another thing that most, including myself, was not aware of. There's a federal law that was created in 1987 called the Emergency Medical Treatment and Active Labor Act. This mandates that any woman in labor must be transported to the nearest hospital, whether that provides OB services or not. So we have 3% of our women delivering in hospitals that don't even provide OB services. How terrifying that would be to me to be an ER doctor and have a woman come in and labor and got to do a stat C-section, and you've never done one. Hospitals are fined if they have a woman leave to turn them away, and they are required to treat and stabilize those women. It is a huge issue that many providers and rural hospitals are not aware of. And quite honestly, I work with some OBGYNs, and I was talking to them one day in the OR, and I was saying, I'm thinking about trying to make an app so that women deploying from Florida can look there and see where the nearest OB department is. They said, Kay, won't do any good because of Untitled. I said, Untitled? And they explained that to me. So in the U.S., Healthy People 2020 goal hopes to reduce infant death rates to 6. Their goal is to reduce infant death rates to 6. Fetal deaths per 1,000 live births. Georgia's at 7. To the effective interventions, after reading all the evidence-based research, a way to address this issue is through improved access to care and prevention. Some of those issues were expanding telehealth. They recommend this in rural counties. Regionalized prenatal councils. The state of New York and California has reduced their maternal death rates by these prenatal councils, which coordinate, plan, and refer high-risk patients. Expanding Medicaid benefits from 60 days to 1 year, at least with measuring what Medicaid also could measure. Incentivizing and expanding advanced practice registered nurses to stay in Georgia and expanding their scope. Notifying all rural and all rural providers and hospitals of the Untitled mandate and supporting rural hospital stabilization efforts. some of the preventive care initiatives, and these were really surprising to me. In Tanzania, which has one of the highest death rates globally, they did a program where they incentivized the male significant others to be involved with the women, to come in for training, to be aware of complications that these women were experiencing and where's the nearest place that they can go to receive care. And it's not rocket science, but it's not something that we naturally think of here culturally in the States. And the other issue is that our African American women are dying at twice the rate of our Caucasian women, with 4 times the complication rate. And interestingly enough, our Hispanic population has much better maternal mortality rates than, not much better, but better than our Caucasian and African American. And they're not sure why, but they're kind of surmising it's because they get a lot of support. I worked with this obstetric group, the Covington Women's Health Specialists, with 2 OBGYNs and 2 midwives for a group prenatal center and model of care, which was absolutely awesome. Instead of meeting your obstetrician for a 5-minute visit, you meet for 2 hours every visit, and they weigh you, measure you, teach the ladies how to monitor their weight, their blood pressure, healthy lifestyles. We even had a pediatric physician come talk to them about immunizations. We had a seatbelt specialist come talk to them about how to strap their baby in appropriately. It was awesome. And Medicaid reimburses better for this model. And there's 20 years of data on this. It's very effective, but a lot of people have not embraced it yet.
Okay, let me jump in here for a moment because we're pretty much on your time. And a couple things I want to say. I mean, this is important, but this is scope of practice, which is where I think you're trying to get to.
Yes.
But there's a separate committee on maternal mortality, and I think this would be more appropriate with that group and what they're doing. So I just don't know how much it's appropriate for this committee to get into the weeds on one specific thing when there's an entire another committee that works just specifically on this.
Right.
So we probably need to try to wrap this up pretty quick and have some questions to get, but focus on scope of practice if you will.
Okay.
I'm trying to do some latitude here, but I do want to
Okay,
keep it.
that was my last slide.
Okay, great.
So, in summary, I think scope of practice expansion is a means to address maternal mortality rates in Georgia.
Okay, and I know there's some people over here that want to have some discussion with you, and they need to do that. One thing I didn't point out here is that Mark and I co-chaired this, and we have sort of been alternating. He chaired over in Augusta the last meeting, so we're equal co-chairs. You have to have one person to kind of run the meeting, and I guess that's me today, is what I want to explain. But with that, let me put the mic over this way.
Thank you for your presentation. Being a former nursing professor, data is very important to me.
Right.
And you took the CDC data, right?
I took a lot of data.
Okay. The last time we had them for 3 years, 12, 13, and 14. Did you look at that data in any other way?
Are you speaking to the maternal mortality
Yes.
review?
I think that's what this was supposed to be.
Yes, I looked at a lot of different data for a
No.
lot of different.
And so you still worked off the for those 3 years, you worked off the 205 deaths between, no, the CDC reported from 12, 13, and 14.
Right.
There were 205 deaths. Is that what you're working off of?
Mm-hmm.
Oh,
And you're referring to, did I look at OASIS versus MMRC?
the Medical Mortality Committee? Right. What was the difference?
All right, the rates displayed in OASIS for 2012, 13, and 14 were 17.7, 43.6, and 68.6.
No, I'm looking for the actual, just so the committee, and I know, our data is coming in very late for the state.
Yes.
We're asking them, we have $200,000 more, if you put it in, probably, for nurse extractors. The CDC gets a number. It is taken from the death certificates, and it just, whoever does the death certificate checks a box. Then the Maternity Mortality Review Committee looks at that. Since the nurse extractor's out, they look at every one of those deaths, medical records, if there was a sheriff's report, whatever. When they did that for those years, 37 of that 205, they could not find any indication that people were even pregnant. And when they looked at that, the number that was actually related to maternal mortality deaths dropped to 101 deaths.
It dropped to a 19.9, 24.9,
I don't know,
and 24.4.
I don't know, excuse me, I was speaking. I don't know where you're getting those numbers, but we've had them in the committee from the CDC and from people reporting. So it dropped tremendously on how many actual deaths we have. And so getting the correct data is really important. One of the leading causes, which was not there, was on hemorrhage, is one of the leading causes of death from maternal mortality rates. We are working on those things in the state, and when it gets to education, we really don't need nurse practitioners. In fact, they're finding there is a much higher rate with African Americans. They're saying it's not 2 times, they're saying it's 3 times more African Americans that die. And what they're finding is not having nurse practitioners, or even RNs, but people from their own communities. More like what doulas do. People who they know that have been educated on going out and talking to them about what they need to look for. People they relate to is on becoming more effective. So I would think that it would be more appropriate if you presented this in the maternal mortality review, but just so the committee would know, there is other information, and we are looking at all of it very carefully for the state. And I know that public health has a big proposal that they have where they want to go to our most critical areas in the state to look at education, facilitating people to know the danger signs, and also just that you would know there is a difference in what's being presented.
Just a quick follow-up for me on that. You did bring up a good statistic, I thought, that was the fact that we're finding that African Americans have 3 times the maternal death rate. It's still low per 100,000. It's still small numbers, but 3 times the rate of Caucasians. Which brought up the other point that I scratched my head over at our last meeting of the Maternal Mortality Study Committee on the House, is that Hispanics are half the rate of the Caucasians. Mm-hmm. And they're small numbers. We're talking about 8, 9, and 4, and 2 in one category, and they're spread across, like you said, hemorrhage, hypertensive problems that are treatable, and then there's other things that are just completely untreatable, embolisms and things. So I think that what we're trying to find out is, well, before we go trying to fix a problem, let's at least find out in the data why is one 3 times, why are Caucasians at 1/3, why are Hispanics half of that? And so I think because it's not socioeconomic and they've been corrected for education, income, and a lot of other things. So I think you brought up a great point that it needs a lot more study for us to make sure we can make some wise decisions about it. And it's still a little early to automatically say that if we had an additional group of practitioner midwives, for example, or a different training program, I'm not sure that maternal mortality data with numbers that are in single digits for a lot of these categories of cause of death, we've excluded car wrecks and other things. So first step was to exclude car wrecks and other things that aren't related, but they just happen to be pregnant. So I think we're getting into that. I hope we can hear back from you, maybe to look over the Maternal Mortality Committee and give that some consideration. It's just a little early on midwives being the automatic answer when we don't really know exactly what's going on.
And I mean, let me make it clear. 1 death is too many if it's preventable. 1 death from a mother is too many. And so we are, just to get that perfectly clear. And if we're running more in the African American community, we need to know why and go after that. So whatever it takes to do that. But I did want to tell the committee, there is a new midwifery program coming. Right now, there's one midwifery program in the state of Georgia. It's at Emory. I have been asking for 3 years for another one, and it is in the early stages. It will be in a more rural area in the south, and I am working with Chancellor's office asking that we give preference to nurses from the community, already living in the community, maybe with experience, that we do something like the MBA program, where, you know, they do much of their book learning online, but then they maybe they work 4 days a week to keep their family afloat, then they can go somewhere for a weekend, 3 days, to get their clinical experience over a period of a year or 2 years, to make it more affordable to many people that are out in the rural community. So that is coming. It will take time for the university system. They've already picked a college. They've announced it yet of where that will be. So that is coming. We are working on getting more midwives in the rural areas that are midwives.
And I do want to say that, you know, the data they've looked at, you've looked at, I haven't looked at it. I'm not current on it. I'm not part of that study. So, and in summary, your recommendation from your view looking at the data is that we need to change federal practice and it would be helpful. And I understand that as a valid point from here. My only thing is, this isn't maternal mortality here, and we can't spend the whole time.
No, I was
Work,
hoping to,
you know.
I had actually requested to speak and was not allowed to, so that's why.
Yeah, well, that's another committee, another time, y'all can do that.
Wait a minute.
Thank you.
I have had no request, and neither has the other co-chairman, had a request to speak at the mortalities. Pardon? Thank you, speak.
I sent an email.
Okay, we'll let y'all address that offline. Anyway, did anybody else have any questions?
Just a quick question to the co-chairman of the committee, because I may not see you again. I was just wondering if the committee on the maternal mortality had looked at expanding the Medicaid from 60 days to a longer period of time, and with the incidence of morbidity be decreased if it were.
We did see the breakdown between the different groups and the timing of death, you know, within a day or 5 days while they're still in the hospital versus a certain number of days later up to 42, and then 42 up to 365. And so there was a good presentation on that. Chairman Hoover's recent committee that we looked at that looked at the validity of including that. So I think that's.
Was it like 90 days or 120?
There was not a discussion about all the breakdown between the 42 days or so that's included now automatically. And we did talk about, I think both of you had mentioned how generous Georgia is with 247% of the federal poverty level being eligible for Medicaid. We even have people who drop their monthly premiums and go on to Medicaid because it has zero copay and zero deductible. With all of the same doctors, so in the same hospitals that are doing the delivery. So I think there's some things in there to look at, and certainly we're looking at overhauling certain aspects of Medicaid anyway with the Patients First Act. So that would be a good one to include, but I haven't seen a fiscal money.
Ever since Blake took over running the Medicaid department and checked with him, I have been asking for an expansion of time that mothers and babies are covered. You know, I asked for a year, and Blake has had that now for what, a year and a half, 2 years has been in charge of the Medicaid area, so I've been asking for that long. I said, if I can't have a year, could I have 6 months, which would cause it so, and every time I see Blake, who's in charge of all Medicaid, I ask him for it. In fact, I discussed with the governor's office yesterday, we need to deal with that.
Okay, we've got a couple more presenters, and I guess I want to say, we said we could work through lunch with anybody that wants to do that. If y'all need a break, we can take one. If not, we'll just move on. Is everybody okay? Continue on. So, I'm not sure if I can pronounce the next name here, so we've got anyway, the APR is a member of the United APR in Georgia. You can do a better job. People mispronounce my name, but I think it's easier than yours. So.
Good morning, everybody. My name is Dr. Ngozi Oroboeze. Dr. Ngozi Oroboeze, O-R-A-B-U-E-Z-E, Ngozi. And I'm here this morning to talk about the nurse practitioner restrictions in Georgia. On July the 12th, the clinic where I worked at got a call from 2 internal medicine doctors from a major hospital who demanded to speak to me. I answered the phone, and the response I got from the other end of that phone that day changed my life for good. That call has encouraged me to be stronger and more committed to doing what I do every day. As I leave my house to the primary care clinic and behavioral health center, where I work on an outpatient basis as a nurse practitioner. The 2 MDs told me that one of my patients that was at the hospital with them told them to call me and thank me for what I'm doing for the patient. The MDs told me that they are not calling. They are not only calling because the patient told them, but more importantly, they are calling to tell me that I'm doing a great job with the patient in the community. All her lab work came back normal, including her blood glucose level, which used to be in the 300 and 400s. And before I proceed, I have one of my patients. All the consent has been obtained. She's sitting right here, and she wanted to come with me to let you know some of the things we do for her in the community. The doctors told me the blood pressure, the blood sugar, the thyroid level, and more importantly, there's a decreased reduction in psychosis on this patient, prompting her to be more compliant with both her medical and her psychiatric medications. The patient I talked about used to go to this major hospital almost weekly before she started coming to the community clinic where I work. In my submitted album to the chair is a testimony of some of the patients I see every day at that clinic. During the discussion with the MDs, they told me that the patient does not have to come to the hospital anymore unless there is an emergency or a great need for a higher level of care. Do you know why? More time and attention is devoted to the patient to track those lab values and follow up more consistently while making changes to treatment plan and adjusting their medication as required. Not that this never happened in the hospital where it would be more expensive, but why should the patient go to the hospital when the same service could be delivered on an outpatient basis by a nurse practitioner at a lower cost? Apart from going to the emergency room for non-emergent conditions, it costs more for the government and insurance companies for these patients with comorbid conditions to go to the ER every time for issues and concerns that could be addressed on an outpatient basis by nurse practitioners, such as basic diagnostic assessments, treatments, medication refills and evaluations. Sometimes all they need is refill of medications that the physicians already prescribed for them while they were in the hospital setting. At other times, it could be blood glucose monitoring for diabetic patients, blood pressure monitoring, pap smear, bacterial and viral infection treatment, therapy sessions, and other health conditions that does not require specialty or emergency care. I've had patients that go to the ER just because they do not like the food served to them at their personal or group homes. They will say they are suicidal. They will be kept, monitored, fed, and the huge bill will be paid by the government. Psychotherapy, individual and group sessions on an outpatient basis by the nurse practitioners will help reduce such behaviors and improve the quality of life for such patients with comorbid conditions. While the nurse practitioners play a major role in supporting the physicians, both on an inpatient and outpatient settings, running the hospitals as APRN, caring for patients and intervening during emergencies as appropriate, the same nurse practitioners are not allowed to practice to their full potentials unless permission is required and acting in the name of collaborative agreement. The patient suffers when the nurse practitioners are not allowed to intervene and deliver the care they have been trained to carry out. I have heard that it is the practice for nurse practitioners to pay physicians who sign collaborative agreement with them. It is common knowledge in the state of Georgia that this practice goes on. This practice jeopardizes the provision of efficient, affordable, and accessible care to Georgia citizens. Because if the MP does not have the funds to pay the collaborative physician monthly, she will not practice, because the state requires the MP to sign a collaborative agreement before practicing in Georgia. Primary and preventive care is denied and reduced when MPs are not allowed to practice at full potential in an unrestricted environment. When primary and preventive care is subdued, you have lots of active and chronic cases which cost more than preventive care. No wonder Commonwealth Fund report that 10 of top-ranked 13 states in national health based on metrics such as access to primary care, early intervention, are predominantly states with full authority practice for nurse practitioners. This was reported in America's Health Ranking 2017. In the same report, 10 of the lowest ranking states restricts NP practice. The legal permission of NP to meet primary care needs depended on maintaining a regulated contract with a physician. And these low-ranking states also tend to have the lowest per capita number of primary care physicians. How does a nurse practitioner who has a DEA license tell a mother who brought her 8-year-old child with ADHD to the clinic because the child ran out of her medications and has been sent home from school due to increased agitation, hyperactivity in school, excessive fighting, and lack of attention in class, that there is nothing she could do to help the child, just because the state law will not allow her to refill Adderall 5 milligram PO daily that the psychiatrist previously prescribed for this child. The state regulation as it is now requires the nurse practitioner to leave all the patients she is seeing at that moment and go find the physician wherever she is before she could write that refill for the child, who suffers in the end, the patient. Care is delayed and care may not be given due to the hurdles of getting to the physician. Currently, 22 states in the USA and the District of Columbia, including Idaho, Maryland, Maine, Alaska, Arizona, South Dakota, Oregon, Rhode Island, and others, have full practice authority for APRNs. The VA have agreed to remove the barriers to MP practice. That means MP can assess, advise, diagnose, and treat patients without physician oversight. In most of the states, with DEA license, the nurse practitioner can prescribe Schedule 2 to 5 medications. Remember, most ADHD medications for our kids and adults, such as Adderall, Ritalin, Fortran, all fall under Schedule 2 medications. More importantly, the Drug Enforcement Administration, through the GAPMP aware, monitors scheduled medications prescribed in our state. They know who wrote them, for who, and when, who is the patient that received the medication, and they know when another provider writes the same scheduled medication, how many providers are prescribing, how many pharmacists are dispensing, as well as the quantity. So there is adequate control and monitoring. We all value our licenses, and the ones that will abuse the drug will still do it, whether they are doctors or nurse practitioners. Removing barriers to nurse practitioner practice in the state of Georgia will not only improve healthcare in the state, but also make healthcare more accessible to more individuals and help to reduce healthcare costs by reducing non-emergent visit to emergency room, and it's going to increase preventive care. In summary, unencumbered license to nurse practitioners in the state of Georgia without physician oversight, as is being done in over 22 states in the USA, will enable the nurse practitioners practice at their full potential, delivering services they have been trained for. It will improve healthcare by increasing primary and preventive care. It's going to reduce costs by reducing non-emergent visits to the emergency room. It's going to increase access to care and improve the overall quality of their life for our citizens. At each point of care, the nurse practitioners still work closely with other healthcare personnel, including physicians, social workers, psychiatrists, psychology, pharmacists, and others to deliver quality care to the patients. Nurse practitioners in the state are currently not allowed to order MRI or CT scan for patients that need it. There are problems getting to the doctors to order these for imaging. Currently, Georgia is one of the states with this barrier, and I'm happy when my fellow PA said they can order that, but the APRNs cannot. With the increasing number of nurse practitioners, the National Resident Matching Program, American Osteopathic Association, reported that this year, the number of U.S. medical school graduates entering primary care residence is about 2,730, a predicted deficit of 23,640 primary care physicians required by 2025. The report also noted that international medical graduates account for almost half of all the primary care residency matches in 2018. Without the international match numbers, the primary care physician supply in the U.S. will be more troublesome. In contrast, there were more than 22,500 nurse practitioner graduates who graduated from primary care program in 2017. In 2018, all the MP graduates were almost entirely United States residents. The report noted that only 8% of national resident matching program this year occurred in primary care specialties, a sharp drop from 11.6% 3 years ago, while 84% of MP graduates are from primary care programs. Nurse practitioners cannot force physicians to sign collaborative agreement, and physicians have the right to refuse to sign collaborative agreement with nurse practitioners. This leaves lots of nurse practitioners not being able to provide needed services and care to patients and improve health care at reduced health care costs. Who suffers in the end? The patient, not getting needed and timely care, and the government paying too much for patients to go to the emergency room for non-emergent conditions. Lastly, one of the restrictions, which I know may not be within the purview of this body, but which may require more study, is the habit where some insurance companies refuse to add nurse practitioners on their panel for patients, even when the collaborative agreement has been signed, and state insurances such as Medicaid and Medicare already enroll the MP. So some of the CMOs say, oh, we cannot enroll the nurse practitioner because, oh, we are filled up. We don't have the space around this community because we are filled up. Primary care, preventive care, or office visits should not require any pre-authorization by any insurance company, as long as the MP is already licensed by the state to provide those services. CMOs should automatically enroll MPs that are enrolled with the state. That is not what is obtained now. Tell me the outcome for a patient walking around with a blood glucose of 400 who ran out of medication 2 months ago and does not have a refill because her appointment with her primary care doctor is in 3 months. Some primary care doctors are scheduled out for even 4 to 6 months in advance. And because patients have no other place to go, they turn to the emergency room. Unrestricted MP practice will reduce such problems. Finally, in the area of behavioral and mental health, the requirement by the DPHDD to the ASO collaborative, forcing MPs to get CAF accreditation, which costs over $10,000 before they could offer simple therapy sessions or individual counseling and psychotherapy, or 1013 a Medicaid psychotic patient who is suicidal or on homicidal mission is not only dangerous to the community, but also increases the risk faced both by citizens and patients with mental health problems. I believe that the above issues are addressed by the state. Healthcare will be more affordable, cheaper, accessible, with efficient and effective care to a lot of citizens in the state of Georgia, especially those in remote areas and have to travel hours before getting to a primary care hospital or clinic. Thank you so much for listening. If you have 1 or 2 minutes to listen to one of my patients that wanted to come with me, she could tell you more about what the primary care has done to her life.
We will, in the interest of time, we'll have to be very brief. I hate to be that way, but we did give everybody, we told everybody the rules ahead of time. So, Doris, go ahead.
Before I came to Dr. Gotti, my blood sugar was between 400 and 500. Since I've been with Dr. Gotti, it's between 130 and 140. I've been in the hospital all my life until I came to Dr. Gotti. I've been with Dr. Gotti for 2 years and only been hospitalized one time in 2 years.
All right, so we certainly appreciate the work that she's done. We know we've got great healthcare people in all of these areas, and I'm sure you're one of them. I know Representative Cooper.
I wasn't going to stand in the back of this again. Emory, which is one of our leading schools with a nurse practitioner program, has 400 clinical hours, 400. And you're telling me in that 400 hours and everything you need to learn to practice, you're telling me that you're qualified to do in-depth therapy, group therapy, and to work with truly mentally ill patients, and shouldn't have to be, I think we don't call them nurse practitioners, we call them a clinical psychiatric specialist in that area, specialized in that area. So you're telling me that every nurse practitioner that gets out of a nurse practitioner program should be able to run group therapy and individual therapy for people who really have psychiatric problems.
With due respect, I did not say that, ma'am. I'm a family nurse practitioner, and right now I'm in school for my side mental health nurse practitioner with Augusta State University. There are qualifications that are required before somebody can offer psychotherapy or psychoeducation or psychoanalysis. But the point I'm making as a nurse practitioner who's gone through the process of registered nurse, who has gone through the process of a master's, nurse practitioner did a board certification and is qualified to provide primary and preventive care in the community to these patients. We are talking about increasing primary and preventive care. That is what we are trained for. I precept nurse practitioners in my practice, and I have my practice, Hca Health and Healthcare Services or Metropolitan Parkway, and I welcome anybody to walk in there any day and see what we do. So there are specialties and there are requirements. I have over 5,000 clinical hours as a nurse practitioner. I precept students from Southwestern University, and I'm also in school. Those are the clinical hours. So I think nurse practitioners are fully qualified to provide services at the areas where they are licensed to do so.
Just want to say, as a co-chairman, I want to appreciate what you do as a nurse practitioner. I think we all are understanding as the field is growing what an important part of healthcare delivery is by advanced practice practitioners, whether a PA or a nurse practitioner. We did hear in our last educational update back in Augusta at our previous meeting the differences in hours of supervised clinical training, not just on-the-job training, like a certain number of hours of shadowing, but it varied from either 400 or 700 up to 1,100 in a nurse practitioner program, to maybe 1,900 in a PA program. With the board-certified physicians, the shortest residencies, the 3-year residencies, having about 14,000 hours of supervised clinical practice after the academic section. I think what we've been seeing, and some studies recently were shared with us that explain that working as a team, I think in rural medicine it's gotten to be much more common for nurse practitioners and physicians to work together to meet that 3 to 4 month delay. And I don't think any of us are talking about restricting the growth of nurse practitioners and PAs working, essentially practicing a form of medicine, but being under and at least being associated closely with some supervision of a fully trained board-certified physician in addition. So I don't think it's an either no nurse practitioners and all doctors, or we just declare all nurse practitioners to be doctors and go out and throw them out to the wolves in whatever specialty they might want. I think that one of the things that we've looked at is there a good way for this to be a team approach? And we just talked a few minutes ago about maybe 4 isn't the right number. Maybe we need to have 8 that you can, or maybe it's a 6 combination of PAs and nurse practitioners where you can adequately work a fully trained board-certified physician. Once again, it's 10 or more times more clinical education. And so they're available because we need them available, because I think anyone will say some things come in and you need backup. And for that to be definitive, it needs to be a written agreement along with chart review that we just talked about a few minutes ago. So I think, do you have a problem with the team approach that we're doing now, or do you not think we're making advances?
I think what you said is absolutely correct. We're making a lot of progress. You talked about 1 physician supervising 10 nurse practitioners, and
4, either 4
4
or
to 5.
Yeah, and then we've talked about it. You can have 8 as long as it's not more than 4 at once. The same way it is with an anesthesiologist and a CRNA.
Yeah, you're absolutely correct. I will just ask on that angle. Oh, yeah, supervising them. What are they supervising? For the state, right now, for nurse practitioners, what is required is one, collaborative agreement signed with the doctor of the same specialty. Secondly, review of 10% of the chart. And then review all of the scheduled medications. So that is the state requirement right now. But
that seems pretty reasonable.
Yeah,
it's not a little bit on the lax side. But I would say
and
if somebody earlier in their practice, they might supervise or assign more charts.
Yeah.
50 or 80% or even 100% of the charts, because they want to make sure that someone who doesn't have a lot of experience in delving into practicing in areas that they're not really well trained in.
Yeah, you're absolutely correct. That's what we're saying. The physicians for nurse practitioners to collaborate with them in the state, we pay them a monthly fee. That's what I heard, and I know it happens. So the physicians that collaborate, assign the
Is that what you do?
I don't do that, but I know it happens. And I've heard some nurse practitioners say that is what happened, because the physicians will require them to pay something monthly to them. And that is where the rule becomes a problem. How do we change that and make sure that these nurse practitioners offer the services?
You say they want to go out and practice, basically practice medicine however they want with nobody supervising, with nobody associated with them.
Again, nurse practitioners can never practice independently on their own. It's always a team effort. I've had patients that walk into my clinic with dermatology problem. I have to refer them to a dermatologist. I have a pregnant woman that walks into my clinic. I have to refer them to the OBGYN. I have a patient that has cardiac problem. I have to refer them to the cardiologist. That is what we are trained for.
I think that's essentially what we were going after. I know we're seeing a lot of new online programs that may not have quite the hours or experience that you do. And unfortunately, whatever we do is going to affect everybody with a brand new printed online degree really equally. As long as they get a license, it's going to treat them equally. And so we're trying to look at the broad spectrum. And I appreciate you going into the psychiatric area to help people, because you're right.
Primary care preventive, more importantly to me, because they're on the streets every day, and we have to help them.
All right. You want to comment?
I don't have a question. I know you said, and I appreciate you coming to Savannah. I appreciate you bringing your patient with you. I think that's very indicative of your passion, that you would bring a patient with you. You said your practice was on Metropolitan Parkway in Atlanta, and I assume that's a clinic. You have an agreement with a physician, and that's one physician, right?
Yes, two.
Two physicians?
Yes.
Could you tell me how much that agreement costs per year for you to have your current model of practice?
I don't do that, but I know some nurse practitioners
You don't have to pay for your
They pay.
protocol agreement?
Some nurse practitioners, they pay. The doctors tell them to pay because before they'll sign a collaborative agreement with them. It's not out there, but that is what is obtained in the state of Georgia. And that is why a lot of APRNs are restricted, because when you go to the physician to sign, they will tell you, this is a condition, so how do we move forward? The patient suffers in the end. So if we remove those restrictions, that will help everybody.
Well, the reason I'm a little bit confused, I had a physician in my county, not a physician, a nurse practitioner, who had a protocol agreement with a pediatric physician, and she had to pay the pediatrician a fee, but then also they had the ability to just drop the contract, and she had to go practice someone else and start all over again.
Some of them charge as high as $1,000 per month for the nurse practitioners. So if you have 5 nurse practitioners, that's about $5,000 per month.
I'm not sure that's, I've never heard that before, we may need to research that further. So we're not necessarily dealing here in reimbursement, and I'm not sure this is what this committee is about, but that's something that we may need to explore. We'll be happy to talk about that offline.
And I'm always open for if you need more information. Thank you so much.
Yeah, if there's specific instances, give us that information, but we don't have that, and that's really not
Yeah,
It don't work.
I don't want to go into this.
All right, well, we appreciate the testimony, and making the trip down here. We've got one more presentation. And we had, at the last meeting, talked about the update in South Carolina on the PA laws. And the year before, they had done the same thing for APRNs, I believe. And so we wanted to have that information. We like to see what other states are doing. Sometimes, whether it's surprise billing or this, any other area, you learn a lot from the other 50 states when you find something that's actually worked. And so, anyway, if you can get that presentation, James Bill, our Senate Research.
Good afternoon. My name is James Beal. I'm with the Senate Research Office. Our office is a nonpartisan asset to all of the members of the state Senate. We provide objective research and analysis. So, as the chairman had indicated, last meeting we talked about the change in the PA law for South Carolina, and he asked me to put together something about the APRN change that happened in 2018. So in your folders you have a memo in there, just a brief listing of the high points of the changes. I'm just going to go through this briefly. So there was actually two bills that they passed, one in 2018 and then a follow-up in 2019. The 2018 bill is S345. The language of that change went from using terms like written protocol to practice agreement, and the way that it was described was more of a collaborative approach. In the practice agreement, there's specific information such as a physician and APRN identifying information, nature of the practice, and the locations, how consultation with the physician and the backup physician is provided, and the physician's quality of care, patient safety mechanisms, the scope of practice authority. They had some changes with their prescriptive authority as well, and any restrictions on the APRN's ability to practice some of the provided for medical acts in the law. So some of the medical acts provided for in the law are going to be to provide non-controlled prescription drugs, and an entity that provides free medical care. They can certify a student that's unable to attend school. They can refer a patient to PT for treatment, and they can pronounce death and sign death certificates. They can issue an order for a patient to receive appropriate services from a licensed hospice, certify an individual as handicapped, and declare a temporary or permanent handicap for the purposes of one of those hang tags or a placard. This was not a change, but I thought it was important to bring up is that South Carolina allows practice to begin without the practice agreement first being approved by the state board. Furthermore, the S345 requires the State Board of Nursing to conduct audits. Practice agreements every 2 years. They further authorize the Board of Medical Examiners at their discretion to audit those agreements. So there's no requirement on the Board of Medical Examiners, but there is one on the Board of Nursing. It further requires physicians and APRNs to produce those practice agreements within 72 hours of an audit request. It added some grounds for misconduct on APRNs. Medical acts or functions performed by the APRN must be within the physician's usual practice, training, and experience. Is the language that they use. Increase the number of APRNs a physician may supervise to 6. And as we discussed in the PA bill made that an equal number as well. They also provided for 6, but it's 6 mid-level providers. So you can either have 6 of one, 6 of the other, or a combination of all. The geographic limitation was eliminated, but the physician is required to practice within the boundaries of the state. The physician must be readily available, and the law provides that readily available is the physician to be contacted either in person or by telecommunication or other electronic means to provide consultation and advice. And the bill also allowed for APRNs to prescribe Schedule II controlled substances. They broke that out into non-narcotic and narcotic, and then also where facilities, what facilities and time limits and time constraints that they can prescribe those. So non-narcotic Schedule II, they can prescribe a 30-day supply. narcotic Schedule 2 is a 5-day supply for one time, and then after that, the physician has to approve those prescriptions. In hospice settings, an APRN can supply Schedule 2 for up to 30 days. So they have a PDMP type program in South Carolina, so APRNs who have that type of prescriptive authority, they have to register with their state's health department. And then they also provided some information in there about telemedicine. That APRN may perform medical acts via telemedicine pursuant to the practice agreement. So the second bill that I mentioned, which was a follow-up bill in 2019, South Carolina, they changed around some of the allowed for medical acts that they perform, such as certify an individual's manner and cause of death, and they can execute a DNR. And additionally, controlled substances, they changed that just a little bit. They tweaked that to allow for narcotic Schedule 2 to be prescribed in long-term care facilities for up to a 30-day supply.
The item up there, number 3, where you said allowing, again, without the practice agreement first being approved, and I'm thinking they're trying to say that credentialing can take forever sometimes to get people working, and it slows it down, but is there some sort of a time frame? Did you see anything on?
No, there was no time frame provided for. They basically just require an audit, and then if when you send that agreement, when you send the agreement to the board, they can review it at their discretion. They just have to do it within those first 2 years.
Okay, well, I think that's too long, but I do think credentialing is a major factor in keeping people working, but I think it needs to be on pretty quick. But that's something I guess we can all talk about. Any other questions?
I get confused, readily admit I get confused when you start talking about all these different practices. In South Carolina, you don't mention the ability to order images. Is that because they can already order images and Georgia can't?
Well, there's no information. There was no information in the law that they passed regarding tests.
Do you know the existing practice?
I do not. I can find that out for you, though.
Okay. And then, let's see, the other question, South Carolina, are they under the board of their nursing, or are they under the board of medical examiners?
It's solely,
Medical examiners.
sorry. Yeah, it's solely under the board of nursing.
The board of nursing?
Yes, and the medical examiners have the ability to audit practice agreements, but there's no requirement, and there's no information about prescriptive authority being approved by the board of medical examiners.
Okay.
And just from a clarification standpoint, Mr. Beal, what I raised earlier with the PAs on the phone at Wellstar, and one of them was the ex officio composite board of medical examiners, is that the issue with the composite board of medical examiners, when they're investigating disciplinary issues for physicians and PAs and nurse practitioners, they have authority over the PA and the physician. But if a nurse practitioner is in that agreement, they have no authority there. Does the South Carolina now, with number 5 there, allow the composite board of medical examiners to do an investigation and have the nurse practitioner testify at the composite board of medical examiners and allow review and action from a disciplinary standpoint relating to all parties involved?
I didn't get too much into the rules that the medical examiners would pass or the board of nursing passed. This is only the statute, but that's certainly something that I can look at.
Thank you. Because that's a gap. That's a gap that we lack in Georgia when it comes to narcotic and substance abuse and boundary violations. And that's something that we should not be overlooking. And that if the composite board is asking for that, then I think that's something that we may need to pay attention to. And then I guess lastly, if we can define, I'm confused along with Senator Underwood here, the non-narcotic Schedule 2. So help me, Dr. Newton and everybody involved. So we're talking about Adderall and Valium, anxiolytics. And then we're talking about narcotics Schedule 2. So we're talking about hydrocodone and morphine and so forth. and so forth. So in Georgia, so in a hospital setting, there are exemptions, if I remember correctly, 5, 7 exemptions, hospital, ERs and so forth. And then outpatient is limited, if I remember correctly, it's 3 days or 5 days. It's
5.
Yeah, is it 5 or 3? And I write 3 days, but maybe it is more liberal in South Carolina than it's in Georgia. Hospice should not be restricted at all, from my perspective.
It's not supposed to be.
Yeah, it's not. But I think that Georgia's 3 days, and I guess this is more liberal, Mr. Biddle, can you?
Yes, it is. So the non-narcotic, as I pointed out, is a 30-day supply, but the narcotic is a 5-day supply there. So
in Georgia's 3 days, if I remember
Are you
correctly.
saying the APRNs or APTs?
No. I'm just about physicians can prescribe, is it 3 days or 5 days in Georgia? Outpatient for Schedule 2s or values is an outpatient. Is it 5? Okay, all right. It was not restricted from your perspective. All right, if we can delve into that a little bit more, I will tell you, I depend on my computer a lot from that standpoint, and it pops it up, and so.
Mary, didn't we have a very big study coming not too long ago, in the past years, about how we are over-medicating the kids in our state with the drugs for Adderall and all those drugs that we're literally keeping them.
Senator Ligon had that.
He did, but the feds are looking at actually loosening that up, including for weight loss. So there was a pendulum back in the 1970s, where it was not controlled at all, to where it's tight control and back and forth. So I think the feds may be addressing a little bit of that too also. Okay, I just want to clarify that because South Carolina seems a little bit more permissive or liberal from that standpoint. Thanks.
Can I just add something to that? One of the things that we had looked at when we were working on the PDMP and those restrictions was trying to get the overdose deaths down. And those deaths are down, but part of the reason they're down is because we implemented the Narcan law and they're being resuscitated. So you don't have as many deaths, but you do have more repeated uses of Narcan.
Okay, but I think they reported that the number of prescriptions written is dropped by 17%.
Yeah.
Still needs to go much lower than 17%, but it's dropped from physicians by 17% being written.
Right.
And many of those deaths are now occurring because of illegal drugs with
Heroin
fentanyl.
and heroin.
Any other questions anybody has of James up here? If not, we appreciate your testimony, and we will, that's all the presenters today. I do want to point out these are 2 separate committees. There are sometimes joint committees. These are 2 separate committees, but the cooperation of us made sure that the people that wanted to come and testify only had to come to one place. It's a county gentler House and Senate. We're trying to get to.
Till January.
I do appreciate working with the co-chairman. He's excellent.
So what's the goal? Are
So
we going to have another meeting?
we will have to, I think by Senate law, and I don't know the House rules, but we will have to vote separately on what we might or might not recommend. And we still need to set that up. And of course, Kate or Patrick's out of the country, so I'll be getting with you all and maybe even have a list of things that say are interested in this or not, and try to see what items we can get consensus on, and what items we can't, and certain people can put in the report things that maybe aren't the recommendation that they should be. That'll be ours. They do their thing over
Do you
there.
know when the deadline is? Is it
We've actually got
December
December
1st?
31st on ours.
31st?
I believe ours is first.
The 1st.
So we'll be moving on that.
Because I think extension still has to be Maternal Mortality.
Yeah.
So do you anticipate the next one to be in Atlanta?
Yes.
For the Senate?
Yeah, I think we'll be in Atlanta.
Are we going to have one more joint one before
I don't
we
think
have
so.
the final one?
I think this
This
is
is
the
it?
final joint
Okay.
taken together.
Okay.
So, I appreciate everybody's work on this and coming forward, and we appreciate the hospital being here and being so hospitable to us and keeping everything great. And the people that took their time last night to visit with us as well, away from their families, I know. I do like to be big about being on time, and I want to find out it's 12:52, we're scheduled till 1, so we've had that goal, if nothing else. And anything you wanted to add, and then you can adjourn us.
I will. I do thank everybody for being here. Thank you for the hospitality from the hospital and the medical school. We look forward to, if we get more information, whether it's in writing, backup information, other stuff, we look forward to making, hopefully, some data-driven decisions, and always keeping in mind the patients, like the ones we presented here, and the care of their lives are what we're all about. Thank you.
Could I get those surveys?
We're adjourned.
Got them, even if they aren't